I'm not a pain expert. This is what I'm pulling from people who are experts and from some of the studies I've read. They referred in this paper I read to pain as like a gate. Okay. And there are certain things that will lower or raise your gait. So this is really going to piss some people off. But the research on like static stretching, reducing injuries pretty much doesn't exist. Here's what reduces injury risk. Not being under recovered. Did you know psychological stress raises your risk of injury?
That makes sense.
Lack of sleep. So they did a study, 4 versus 8 hours of sleep. Guess how much it increased injury risk? 230%.
From that much less sleep.
From 4 hours less sleep a night. You can desensitize yourself to pain. You can also sensitize yourself to pain. So actually one of the most effective ways to decrease pain is through what's called exposure therapy. Essentially, you're trying to touch that pain just a little bit without making it worse. Lower the weight a little bit. Does that help? If that doesn't do it, lower the weight, slow the tempo down. That doesn't do it, try lowering the weight, slowing the tempo, and doing a pause. That doesn't do it, lower the weight, slow tempo, pause, and modify the range of motion. And if all those things don't work, then you got to regress.
You're done, dude.
Then you got to regress to a different exercise until you can build your tolerance back up.
To that.
I think the mistake a lot of people make is it's like what I used to do, which is either, okay, well, I can't train, so I've just stopped training, or I try to plow through it. It was like 2 speeds, right? Yeah. Pain is more like an emotion.
Number one, let me say I feel for Lane Norton here. He's getting asked on a podcast about pain, and pain is not within his scope. He is a strength coach and a power lifter and a PhD in nutrition, which is actually how I found Lane Norton, was looking up nutrition information. But rather than skip or pass on this question, he ends up perpetuating certain myths that I would say fall into the area of current trending expert belief that doesn't actually match the body of research. And let me kind of break this down. He starts by talking about static stretching not preventing injury. And he's not wrong, but he's also only half right. And unless you know the full body of research and you happen to be a physical rehabilitation specialist, like an athletic trainer, physical therapist, or chiropractor, I'm not sure if you would catch the nuance. Here's the problem. If you do a general stretching program without assessment, the chance of you doing anything really productive is not great. But when you start looking at the research where mobility techniques are being used to address assessed restrictions, things look a little different, right? We actually do see increases in performance. We see increases in mobility. And although we're still missing some pieces of the puzzle in research because we don't have really great long-term prospective studies that compare stretching to non-stretching and risk of injury over time, we have enough evidence to suggest that if you're addressing an assessed restriction, that's a good thing. Okay. Lane Norton then goes on to talk about a lot of psychosocial issues involved in pain. And everything he said was right. So I can totally see cutting your sleep under 4 hours significantly increasing your risk of injury. Stress, absolutely, will magnify or amplify pain and symptoms. But the idea that these psychosocial issues are the cause of pain is part of this very strange pain science movement that does not match the literature. And if you ask me, it's part of what I call excuse-driven therapy. Realize that psychosocial issues are outside of the physical rehabilitation specialist's control, right? It's one of those things where I go and do my physical therapy intervention on a patient and they're not getting better. And I go, well, it must be because they don't get enough sleep, right? It's excuse-driven therapy and I hate it. There is a lot we can do as physical rehabilitation specialists, even if the psychosocial stuff isn't great, right? So I'm not saying that Lane is wrong there, but for it to think about it as the cause of pain or to think about it as optimal intervention planning to like fix those things is half-assed at best. All right. He then goes on to say that exposure therapy is one of the best therapies. And on this, I'm calling bullshit. Exposure therapy, graded exposure, which is what he's referring to, is not physical rehabilitation. What an ATC, what a DC, what a physical therapist does is not just slowly expose you back to the thing that hurt you. That's not rehab. That's laziness. That is the most archaic intervention planning I can possibly think of. And there are literally thousands of studies demonstrating more effective methodologies, from joint mobilizations to joint manipulations to ischemic compression to certain modalities like taping and ISTM, and of course specific exercise interventions and home exercise plans, and then of course progressive loading via exercise. All of that happens before I ever talk to a patient about graded exposure. Graded exposure is the discussion I have once we've reduced all assessed impairments, the things likely contributing to their pain and injury, to get them back into physical activity and slowly ramp them back up to the intensity they were doing previously. Again, it's not that we don't do graded exposure, it's just that that's not physical rehabilitation. If you think graded exposure is physical therapy, please leave my profession. It's just laziness. There is so much more we can do. He does talk about a strategy in his weightlifting where he kind of reduces stress. It wasn't a horrible strategy, but I think if you have a good knowledge of biomechanics, you can actually do quite a bit more than just like reduce load or reduce speed or reduce range of motion. Sometimes you can change planes of motion. You can change body positions. You can choose different exercises. And I know this becomes kind of problematic for powerlifters because you guys have certain lifts that you need to get better at, but there are usually alternatives to help keep your strength and conditioning at a certain level, so that then after we get through the physical rehabilitation piece, we can kind of move back into the lifts that you do need to work on. Again, I feel for Lane being cornered on a question outside of his scope, although I do hope that if I got asked about nutrition, I would pass on the question. You guys have heard me talk about the fact that we need to up our game and start looking for research-supported experts and not just experts. And I do believe Lane is that research-supported expert when it comes to nutrition, just not when it comes to pain and physical rehabilitation. And why should he be? He's not a licensed clinical physical medicine professional. That's not what he does. If you guys have any questions, comments, requests for research, please let us know. You know that at the Brookbush Institute, we are dead set on creating the most accurate content ever created via the first comprehensively evidence-based education platform. We have every course is built on a systematic review, so obviously all the research is there. And most off, we want to help, right? So we're here for our colleagues. Anything you guys need that we can provide, we absolutely will. And Lane, if you have any questions, man, or you want to debate or you want to counter anything on here, I respect the academic process. You absolutely have the right to counter. And I will absolutely appreciate and respect that. We'll talk to you guys soon on our next response video.